Right.
What are you doing?
Roll over, please.
Tommy, have you gone and forgotten everything you learned from third year? Luckily, we have just the man to sort you out.
Now then, Tommy, I hear you've forgotten how to examine the cardiovascular system. Did you even wash your hands? Didn't think so. Students. Right, let's start again. Once you've introduced yourself to the patient and gained consent, position them at 45 degrees and expose them appropriately from the waist upwards. Now, step back, Tommy. Don't pretend like you did in that ill-fated driving test and actually look for clues. Are there any ECG leads, oxygen masks or GTN spray around the bed? These are signs that no medical student should miss.
Are you in any pain at all? Do you mind just popping your hands up?
Excellent, Tommy. Now, ask the patient if they're in any pain and ask to examine their hands. Look for any peripheral signs of cardiovascular disease. The classics include clubbing, peripheral cyanosis and a poor capillary refill. The more exotic cases may include Osler nodes, Janeway lesions and splinter hemorrhages. But remember, if you're going to give any of these signs, make sure you know the causes for them. Super work, Tommy. Now, feel both radial pulses and offer to check for a radio-femoral delay. When feeling the radial pulse, remember to check the classic three: rate, rhythm and character. Ask the patient if they have any shoulder pain. If they do not, raise their arm and check for the characteristic collapsing pulse of aortic regurgitation. Great banter, Tommy. Now, inspect for any xanthomata or scars that can be seen. And remember to always state that you would like to take the blood pressure. A narrow blood pressure is indicative of aortic stenosis, whereas a wide blood pressure is indicative of aortic regurgitation. The JVP is a representation of the blood pressure in the right side of the heart. Look at the column of blood in the internal jugular vein and measure its height above the angle of Louis. Normal height are 3 centimeters or less. If you want to check the waveform, feel the carotid pulse simultaneously, remembering that A waves represent atrial contraction and V waves occur near ventricular contraction. Remember, Tommy, not to get the carotid pulse and the JVP mixed up. An easy way to differentiate between the two is to perform an hepatojugular reflux. This manoeuvre causes the JVP to rise but does not affect the carotid pulse. Other distinguishing factors are the JVP's double waveform, its occludability, and its variability on position change. Assess the carotid pulse in isolation, confirming the rate at the wrist and assessing the character more closely. A pulse that reaches crescendo slowly is termed a slow rising pulse and is indicative of, that's right, aortic stenosis. Inspect the face and the eyes for malar flush, corneal arcus and xanthelasma. Check in the mouth for dental hygiene and central cyanosis. Moving swiftly on to the precordium, look for any visible scars or heaves. Then inform the patient that you will be palpating for that apex beat, moving from the most lateral position to the 5th intercostal space, mid-clavicular line. Once you have located the apex beat, determine its position by counting the number of ribs from the angle of Louis. Determine whether the apex beat is normal, tapping or heaving. Assess for a right ventricular heave and feel for any thrills in the upper precordium. Now, Tommy, we can finally whip out our weapon, the trusty stethoscope. Repalpate the apex and listen using the bell. Move the patient into the left lateral position, checking for any radiations in the axilla consistent with mitral regurgitation. Now, return the patient to their original position and auscultate the 4 areas with the diaphragm. The areas of auscultation are the mitral, which is found in the 5th intercostal space, mid-clavicular line, the tricuspid, which is the 4th intercostal space, left parasternal, the pulmonary, which is second intercostal space, left parasternal, and finally the aortic, which is second intercostal space, right parasternal. Listen in all 4 areas systematically. First checking for heart sounds of S1 and S2. Differentiate between these by simultaneously palpating the carotid pulse. Then check for any added heart sounds, and afterwards pay attention for any murmurs. If you suspect you hear a murmur on the right side of the heart, getting the patient to take a deep breath in and holding it will accentuate that murmur. Likewise, a murmur on the left side of the heart can be accentuated by getting a patient to exhale and hold it. Remember to always check the carotid area for any radiating murmurs. Now Tommy, lean the patient forward and listen at the left lower sternal edge. Here you should hear the characteristic diastolic murmur of aortic regurgitation. Remembering though, that the systolic murmur of hypertrophic obstructive cardiomyopathy will also be loudest in this region. Now that you have the patient leaning forward, auscultate the base of their lungs for pulmonary edema. You may also at this point want to check for any renal bruits. Ask if they have any pain in the lower back or legs before checking for sacral or ankle edema. Thank the patient, make sure they're comfortable, and state to the examiner that you'd like to perform examination of the peripheral pulses, check for abdominal aortic aneurysm, and perform fundoscopy.
When you listen to his heart, there's
Whoa. Okay Tommy, full marks for effort. But OSCEs aren't just about examination, they're about sounding slick. So, Mr Gamble is a 21-year-old gentleman who is comfortable at rest. He has no peripheral signs of cardiovascular disease. He has a heart rate of 72 beats a minute, and his character and rhythm are normal. His JVP is 3 cm above the sternal angle. His apex beat is found in the 5th intercostal space midclavicular line and has normal character. The heart sounds of S1 and S2 are audible, there are no added heart sounds. However, there is a pansystolic murmur loudest in the mitral area, which radiates to the axilla. This is consistent with mitral regurgitation. Well then Tommy, I hope you've learned something today. If you have, bravo. But if you haven't, I will not be held responsible for your blunders in the future because you have not been listening carefully enough. And for you out there, I'll see you on the wards.